and we're going to have Matt Messerschmidt talk about some of his really innovative outreach programs that he's had there in Health Point. It's called Project Handle, and so we're going to learn a little bit more. Matt, take away. You can, there you go.
So just to clarify, I actually work a few different part-time jobs through different organizations, and so I do work with. I'm here today, as part of our Health Point program, but then separately am the medical director consultant for Project Handle, which is a part of Neighborhood House. So we'll get into that, and I'll just say next as we go through. So you can go on to the next slide. No disclosures. And the basic ideas I'd like to hit on today are kind of brief, not particularly systematic review of this kind of intersection between hepatitis C, mental health, and substance abuse. And then how our program, Project Handle, does community outreach and some of the efforts that we've done, some of the challenges that we've come across. Next. So this again is just that, sometimes in medicine and academics we tend to silo these ideas of mental health, substance abuse, or infectious disease, but we all know from seeing our patients that they directly intersect and create feedback loops on each other. And so wanted to explore a little bit about how that happens next. In terms of starting off with just the Hep C, I think everybody on this, here today is pretty familiar with the hepatitis C cascade of care. And this is just a reminder of where some of the big differences lie between, say, like the HIV cascade of care and the Hep C cascade of care. And then one of the biggest differences is in the initial identification of people with hepatitis C. So, only a little over 40% of people know that they have hepatitis C who are carrying either the virus or antibody. Next. And recently, as of 2010, despite the improvements in our treatment, we've actually had an increase in cases of hepatitis C, acute hepatitis C, which is, our best kind of indicator of how many people are getting the infection each year. And with the opioid epidemic and rise in rates of injection drug use, that's really fueled ongoing acquisition of hepatitis C in our communities. Next. To nail that down a little bit more, some of the stuff I was seeing from CDC would say 75% of people who inject drugs are believed to be Hep C antibody positive. And then digging in a little bit deeper, it seems like that has actually changed over time, with some studies in the 1980s showing up to a 90% lifetime risk for people who inject drugs, and very high risk even within the first few months. Some of the more recent data in the CETUS studies, and those are studies within 4 large US cities that you see listed there since the mid-90s up until the mid-2000s, show a decrease in the prevalence of people who inject prevalence of Hep C among people who inject drugs. And so just another study that looked at meta-analysis of 77 studies, kind of cut to the developed countries after 1995, and was seeing that the rates for that were, even in the first year, about 30% of people becoming positive for Hep C among people who are injecting drugs, and 50% within 5 years. So some kind of smattering of numbers depending on exactly what populations were studied and when, but I thought that was interesting to get a little bit better idea on that. Next. Another question that came up was, so we know Hep C, the Hep C epidemic is being driven by people who are using injection drugs at this point, the new acquisitions anyway. And so I was curious how much people who are using injection drugs are engaged in care and knowing about their Hep C status. I was really only able to find one study that ended up being from a college friend of mine. And he looked at needle exchanges in Wisconsin and found that about 90% of people had ever been tested, and even set, 3/4 of them within the past year. So I would call that pretty good risk-based testing among that population. And some things that he looked at or found to be correlated with more likely to have been tested in the last year are people in urban or suburban areas rather than rural areas, people with a higher education, people who are already linked to care with their primary care provider, or if they had a history of overdose and presumably went to the hospital and got tested as part of their overdose history. They also did, this is a mixed methods paper, and they did some qualitative research with people and asked people why it was that they had been tested. And people pointed to these ideas: wanting to stay healthy, wanting to reduce their anxiety about not knowing their status, and they were more likely to, and also wanting to protect their friends, lovers, etc. They also were more likely to have been tested if they felt like they were in a place that was non-judgmental and with a provider with whom they had rapport. There were a fair number of people who identified this feeling of fear, just not being ready to know, or they were kind of in a state of denial about their potential hepatitis C status that kept them from getting tested. Some folks had low self-assessed risk that may or may not be, objectively truly low risk. Kind of the flip side of that non-judgmental comment is the stigma, and then transport time, cost of getting the test, getting it covered, getting to the clinic to get it done. So next. And so, kind of talked about IV drug use pushing the epidemic, how people with IV drug use are engaging. And then I wanted to get into this overlap or intersection of mental health and substance abuse. And, I had the kind of qualitative experiential idea that people with substance abuse disorder and mental health disorder goes together, but these numbers of 4.6 times the risk of a substance use disorder for a person with schizophrenia, and 2.5, I think it says, for folks with affective disorders. So I just thought that was kind of interesting to put some numbers to that. Next. Aside from the actual increased risk that goes with having a mental health disorder and being more likely to use IV drugs, this paper looked at people with severe mental health disorders and identified that they were, in general, more likely to have Hep C and have risk factors for Hep C. So almost 20% of this population with severe mental health disorders had a Hep C diagnosis. You can see the rates of Hep B and HIV there as well. And but 3/4 of them identified a history of IV drug use, but that's not so different from the proportions from some of the studies that we looked at population-based. So these people have other other risk factors that are also giving them higher rates of Hep C, and some of those are potentially non-IV drug, or the 7 below that have a smattering of other potential risk factors that are not our traditional direct risk factors. Next. Another paper looked at more directly IV drug use and mental health, and noticed basically that people who have whose mental health symptoms are not controlled are more likely to have anxiety and more likely to share share IV paraphernalia, whereas people who are on psychotropic meds, who are more engaged in their care, are seeming to share less. So next. And then I just wanted to bring up this idea that, that we've all been familiar with, that the other way that mental health has interacted traditionally with hepatitis C is in the barrier that it caused to treatment of people with hepatitis C, because of the obvious difficulties of interferon-based treatment worsening mental health, and so some of the very people who were most at risk of getting hepatitis C were the most difficult to get through treatment. Whereas now with DAAs, we're really, I think, as we just kind of talked about with the folks at Western State, we're really able to treat people just in spite of some really significant mental health issues. Next. So kind of into this, into that sort of environment, there is a collaboration between SAMHSA, Neighborhood House, and NAVOS. So SAMHSA put out, through its Minority AIDS Initiative Continuum of Care pilot, a grant that was picked up by Neighborhood House and NAVOS. Neighborhood House, in case people are not familiar with it, is a community-based organization that's been around since the early 1900s. They've traditionally been kind of an immigrant and refugee support organization, and have branched out from there. They do a lot around aging, supporting people who are poor and aging or disabled, promoting early childhood education, employment, et cetera, housing stability. And then they do have a community health arm, and among the projects in their community health arm are this Project Handle, and that has two arms, which we'll get into. One is called Project Handle at NAVOS, and the other is Project Handle Prevention. The NAVOS arm collaborates with NAVOS, which is a major mental health provider in South and West Seattle. And the prevention arm is more of an full community outreach arm. So next. The Project Handle has a couple of target populations that are kind of overlapping in its two arms: African Americans, Latinos. The NAVOS arm focuses more on adults, and the prevention arm focuses more on youth, 13 to 24. Both of them look to get prevention messages out into the community, so prevention of both viral hepatitis and HIV. They seek to get people tested so that they know their status and have an early identification in the illness course. And they seek to link people to care for both viral hepatitis, HIV, as well as mental health or substance abuse issues that people are encountering. Next. So the main way that I'm involved is in developing and training around the point of care testing and protocols there. We use an Alair 4th generation HIV test. That's the first point of care 4th generation HIV test. You can see that's the left of the two tests in the bottom corner there. And you can see that there are two test lines, and so there are actually three lines that show up. One is a control line, and then one is the traditional antibody line. And then there's also the antigen line that shortens the window period, P24 antigen line that shortens the window period, and gives this test or counseling. And I mentioned the kind of linkage to care that they do.
Hey Matt, sorry to interrupt you. We lost you for about 45 seconds there.
Uh-oh.
Any,
Did I get through the aura quick before you lost me?
why don't you just go over the aura quick, real quick?
Okay. So Alair is the 4th generation HIV test, and uses the P24 antigen to decrease the window period. Aura Quick is the only available point of care.
Uh-oh.
Our community health associates do a risk assessment with people to identify sexual and drug use risk factors for HIV and viral hepatitis. And then they use motivational interviewing to try to bring people to the next step toward behavior change. They also introduce ideas of PrEP and STD testing, and then link people to care on an as needed, as interested basis. So they link to Navos for their mental health, for folks' mental health needs. For people with primary care needs, STD testing, or hepatitis C, they might link to Health Point or other community health centers like Country Doctor. And then for people with HIV and Hep C, they would link to Harborview, the Madison Clinic. Some of our programs also do mental health questionnaires to further identify who needs that kind of mental health support. The others run support meetings that kind of keep people engaged over a long period. That's our Project Handle Navos folks. And then our Project Handle Prevention folks run workshops that seek to help people kind of develop some empowerment around talking with their partners about condom use. Next. So, part of the goal here is to reach people who don't otherwise know their status, and there are a few strategies that are used there. One is just the good old compensation. So we don't actually compensate for getting tested, but we do compensate small gift card for participation in our questionnaires, and often that's enough to bring people into to do the testing as well, since they're already there. We place a big emphasis on being culturally appropriate, and that really happens from who our community health associates are, and those are the people on the ground. They're really coming from the communities. Many of them are African American or Latino. Many of them are LGBTQ. And so they're engaging with people in a way that is kind of naturally culturally appropriate, and I think they carry a certain veracity. Their word kind of carries a certain veracity because they're from that community. They also assist via social networking. So sometimes this is friends or cousins of the workers that might become a client of our program. At other times, somebody might be looking like they're nodding out on the bus route, or looking like they're confused about what needs to happen on the bus, and so one of our workers might approach them and see if they have any mental health, substance abuse, or needs, or would want to be a part of our program. And then the fourth way that we do this is through location-specific outreach, and I'll go to the next slide to discuss that more. And so this is basically just our folks going out into the community at places that they're familiar with to really target people where they are, rather than asking people to come to us. And so you can see the Route 120 really hits the bus Route 120 really hits some of the places that we hit. Pioneer Square, White Center, and then Burien transit stations tend to be hubs of people who are selling or using drugs, and so that those are places where our folks go into. We also go into some parole programs and try to hit people who are recently incarcerated or on parole. Homeless shelters, as well as meal sites or tent cities that are part of homeless encampments or meal sites that bring people in. I mentioned kind of the social hubs, and then some of the challenges that go along with this are coordination with such a wide variety of often kind of informal sorts of areas, and somewhat of a challenge to find the right people to coordinate with. To find, we do have a van now that can go out and do mobile testing and counseling, so that's been helpful in overcoming some of those barriers around space and coordination. Next. Despite, I think, looking for us going out into these areas and really targeting folks that seem to us to be high risk, on the one hand, we have rates of alcohol use in our group of about 30%, our client group, and on the other hand, only about 9% are currently IV drug using or within the past 3 months. So it's still somewhat, I think it's a challenge still to find people when they're, when they're first starting IV drug use. Next. Just to give kind of a brief overview on some of our outcomes, we've tested a total of about 860 HIV tests and 650 Hep C tests over the course of the grant. We're coming up on the 4th year of the NAVOS grant and the 3rd year of the prevention grant. They're kind of slightly offset grant cycles. But and of those, we've gotten 6 HIV positive and 18 hepatitis C positive cases. One of our challenges has been getting people back for confirmatory testing, and so you see of the 26 preliminary positive Hep Cs, 21 have made it back, and that number, oftentimes that takes us sometimes 3 months or 6 months to pull people back in due to the transient nature of their life, and so often they're kind of not so ready to deal with that diagnosis or confront that diagnosis. Next. So I mentioned kind of before some of the things that I feel like are still some challenges. I feel like we do a good job at getting out into the community, but it's still hard for us to hit really a high proportion of at-risk individuals. The confirmatory testing has been difficult, and especially confirmatory testing for hepatitis C, because there's no we don't have venipuncture with our folks, largely due to the kind of administrative norms of the neighborhood house as a community-based organization rather than a health care organization. Likewise, we've done some trainings around naloxone, but there's been some barriers to getting naloxone into our CHA's hands and out into the community, but hopefully we are getting that word out into the community at least. And then even CLIA-wave testing is, though it's pretty straightforward, getting kind of lab protocols done with non-lab personnel has been somewhat of a challenge that I think we've made it through, but was a little bit more difficult than I had originally anticipated it being. because it's a grant-funded research, grant-funded project through SAMHSA, and there's a research component to it. There's a lot of kind of legalese that goes into the consent process, and I think that that's been somewhat of a challenge with our community. And then occasionally, our CHAs are from the community, and that really gives us that entree that I think that would otherwise not exist. On the other hand, sometimes it's been a challenge to change some of the beliefs in our own staff. Has been kind of the first challenge toward changing beliefs in the community. So I think that's both a challenge and a great benefit, because it really helps us identify what are the areas that of resistance or suspicion in the community around some of the messaging that we're providing. And so next. And so, just the last kind of comment on this, I think the reason that I have sought to engage in this sort of project is it really helps me answer this question about which patients am I responsible for. I think the traditional view of medicine has been that I'm responsible, for the patient who's made it into my office. And as we're moving toward more of a public health look, we're often doing population management within an institution, but that still really leaves out people who are in our communities but not yet engaged in our institutions. And so I've been happy to be a part of this in order to kind of engage with that